All right, so welcome and thank you for joining. I see our attendee number is slowly climbing, so we'll just take a few moments until everyone's joined. You are welcome to the Sexual Health and Bleeding Disorders webinar this evening with Hemophilia Ontario. Just taking a few more moments. It may seem like you're entering an empty Zoom room right now, but if you look in the top left corner of your screen, you can see that attendee number and the panelist number as well, if you're curious how many people are in the room with you. And we'll get started shortly. All right. So I guess we'll get started. So to begin, my name is Kaylee Rajna, and I'm just going to be going over a brief housekeeping slide before we get started on tonight's webinar on the sexual health and bleeding disorders. So I'm sure at this point in the year, everyone is very familiar with Zoom meetings, but I did want to highlight as there are some nuances between Zoom webinar and Zoom meetings. So as an audience member, we cannot hear or see you, but we can see in the top left corner of your screen. If you hover over that bar, there's actually 17 of you here with us tonight. So once again, welcome and thank you for joining us. So following the presentation tonight, we will be doing a question and answer period. If you'd like to ask a question verbally at this time, if you advance the animations on the screen, you can select the raise hand button, which will then give you a prompt to unmute yourself and ask your question if you'd like to ask verbally. There is also the Q&A portal, which you'll see in this next animation. So this is available throughout the presentation. So if you do have any questions throughout the presentation, we encourage you to ask throughout. And please note, you do have the option as well to submit anonymously, should you prefer to do this. So one more animation there. And then if you do see a question that you agree with and you would like to hear more, rather than resubmitting the same question, we do encourage you to use the upvote button. So it looks similar to that like button on Facebook. This will bring the more popular questions to the top of the screen and ensure that we answer those questions that are most interesting to all of you. Finally, we do have some polling questions, which Boyan will introduce shortly. These will come up as a separate polling window, so simply select the option that you would most like to vote on. And then when you press submit. So in this case, there will be a few, so you will need to scroll down and select all your options before submitting. I will also take a few moments to pause as I see the number of you participating to get the most, hear from the most of you. So last but not least, we will also be recording tonight's webinar, which will be made available following tonight's event. However, it will be simply the presentation and the question and answer period, and your participation will remain anonymous. So without any further ado, I will pass it off to Boyan to kick off the evening.
Thank you so much, Kaylee. So my name is Boyan Piernet. I'm the Member Support and Services Coordinator for Hemophilia Ontario. Thank you all for joining us for Hemophilia Ontario's first sexual health webinar. We're very excited about the program and the speakers we've got lined up for you tonight. So before we even get started, as Kaylee mentioned, we're going to do a short poll to get an idea of the audience and your baseline levels of knowledge and who you are, where you're from, but all answers will remain anonymous. So I'll give you a moment to fill that out on your screen as it should be popping up.
So again, you will just need to scroll down and submit all of your options, and then your responses will be recorded there. So I'm going to wait a few more moments while everyone has the chance to participate. Wonderful. All right.
Okay. It's got some interesting results here. Pretty mixed bag. A lot of people who are in the other health professional and friend categories. If you scroll down a bit, or I scroll down a bit, actually. Interesting. I'm surprised by a lot of people feel very comfortable actually speaking with their healthcare providers about their sexual health. And a lot of consensus, 12 people thinking that healthcare providers 100% should be having discussions with their patients about sexual health. Wonderful. Thank you so much for filling those out. The answers are very interesting and illuminating. So we get the show on the road. Just a few housekeeping notes before we get started. So all the participants, as has been mentioned already in the webinar, will be fully anonymous, and your names are not going to show up in the recording, and unless you choose to identify yourself in the chat or something like that. So tonight's webinar is going to be, so later tonight you'll be free to submit your questions in the Q&A section down at the bottom of your screen, where you can submit questions either during the presentation, or you can hold them back until afterwards when we get to the question portion. So the structure tonight that we're going to be using for this webinar is this short intro, which I'm sure you're all enjoying very much. Then we're going to be moving on to a presentation from Greig Blamey, a physiotherapist at the Hands Clinic and Bleeding Disorders Program at Health Sciences Center in Winnipeg. And fun fact, my physiotherapist until I was about 22 years old. So we've got also two patient speakers who are going to be coming at sexual health from two very different perspectives as well. And we're going to be doing an interview with two of those for that section. And that interview will sometimes include Greig, depending on what the topics are at that time. So following that, we're going to have a question period and then closing remarks, and then you all get to go home and either have dinner or enjoy the rest of your night. So we hope that tonight's going to be the beginning of a conversation. And with that in mind, we've structured this webinar in a much more conversational format. With the participant, we're going to be trying to cover the physical, mental, and social aspects of sexual health, but we're going to do it in a kind of conversational way after Greig's presentation with an interview with the two patient participants to really get into the nitty-gritty of what it's like with the real life, raw kinds of experiences people have, and not focusing too much on one area or another, but opening up the conversation and hopefully showing you the complexity of this issue and how it affects patients. So without further ado, I'm going to pass it over to Greig and get us started.
Great. Okay. Well, thank you so much, Boyan, for that introduction. And thank you also for the invitation to participate in this webinar. You know, this is a topic that many of you, if you know me at all from the past number of years, this is a topic that became of great interest to me a number of years ago. And as a physiotherapist, I just want to be clear that my expertise obviously is in the way that the body moves and the way that the body works. And so my approach to sexual health in terms of bleeding disorders is really coming from that musculoskeletal, more physical aspect. And that's where my expertise lies, and that's really where this talk comes from. So it's not going to be a talk that incorporates things like safer sex practices as an example. Not that that isn't critically important, but this is a talk about sexual health from the angle of a physiotherapist and joint and muscle health. And I think that the reason that so many of you in that polling question are so comfortable with this topic, I would like to believe that it's because over the last number of years, for sure, Canadian clinics have become much more adept at bringing these issues forth and inviting these discussions with the patients when they come to the clinic or engage with the treatment team. And it really wasn't always the case. And so my objectives for this talk, first of all, are to kind of examine how healthcare teams, which includes patients, of course, work together on this topic and bring the issues that need to be brought to light, bring those forward. I want to identify for you what some of the range of physicality that's involved in sexual activity is and why it's important for people with hemophilia and other bleeding disorders. I want to make a legitimate case, frankly, for all of you as to why there is a potential for musculoskeletal bleeding when it comes to sexual intercourse and sexual activity, which is not always an immediate connection that people make. I want to talk a little bit about alternative positions that can be used, alternative techniques that you can use that increase pleasure, but also decrease risk of injury. And then because we are where we are in the middle of a pandemic, we've got novel therapies that have come online within the last couple of years. I want to talk a little bit about the relevant research that exists in this field and in this space, and do a little bit of a real world kind of context taking exercise to see where we're at on this topic as we sit here in the middle of a pandemic in 2021. So, I mean, no matter what you believe in terms of an origin story or not, this is a topic at its core that the topic we're really discussing has been around for all of recorded time. My interest in this topic really started in a presentation or a formal kind of way at the World Federation Congress that ran in Vancouver, close to 15 years ago now. And the reason that I was so interested and spoke at that conference was because it was the first time that we had realized at our clinic that we needed to deal with these kinds of issues with respect to treating active bleeds and recovery from bleeds. And it all came from one patient. It started off with one patient who, for the purposes of this presentation, we're going to call him Mr. XXX. He was a young man, 21 years old, severe factor IX patient, and he developed a series of iliopsoas muscle bleeds over a period of 6 months, 3 massive bleeds in 6 months. And when we finally cottoned on to the fact that it was sexual activity that was causing his bleeds, what it led to, that one case led to procedural changes that swept right through our clinic across the board to dealing with all of our patients. And frankly, that led us to discover other cases within our clinic who had bleeds very similar and from a very similar cause. And the kind of alarming part was that the standard advice we were giving at that point, quite frankly, was contributory to these problems developing, which was pretty horrifying for a treatment team to learn. This is just one CT scan, just showing you on the right-hand side of your screen the size of that iliopsoas muscle bleed in this gentleman compared to the left side. And I'm not sure if you can see my cursor, but I mean, here's the iliopsoas, here's the bleed in the middle of the muscles surrounding it. And on the other side, where there is no bleed, you can see the size difference and how much blood was held in this iliopsoas muscle. It's a massive, massive bleed. And so prior to this particular case, we never asked questions about sexuality, about sexual activity, whenever we were dealing with our patients. And that has really changed because of, it started off with this one case. But when we looked at his records, what we found out, because remember, this is 15 plus years ago, so we're talking about someone who was on standard therapy, so infusing a couple times a week, and we always realized that his bleeds were happening the night before he would have given himself his next prophylaxis dose. So his trough level was approaching its lowest level, and he was approaching one of his most active times of day. And those of you who are on the webinar who have hemophilia, and if you are of a certain age, and I'm going to say if you were at least 20 years of age, you will have been told by your treatment team to never infuse at night, because that would actually be a waste of product, because all you're going to do is go to sleep, which is a massive assumption, frankly, which is not quite correct. And that you really should be infusing in the morning so that you have the highest levels during your active part of your day. But the problem is, at least for this gentleman, the most active part of his day happened after 10 p.m. If you look at what we used to tell people about their activities of daily living and how they should choose sports and recreational activities, you have to be very careful about choosing sports and activities, but just do your activities of daily living. And sexual activity, quite frankly, is an activity of daily living. And so it kind of just got lost in the shuffle, in the conversation, and never talked about specifically. And as I said, sex for this young man anyway was literally a daily activity for him and his girlfriend. And so now, because of this one case, we discuss sexual health issues with all of our patients post-injury. We discuss them as part of the routine physio evaluation and annual clinic visits. We discuss all of the matters related to sexual health and sexuality, and we invite those from the patients, those conversations. We invite them from whoever they wish to raise their issue on their behalf, if it's one of their support system members, their parents, their girlfriend, their boyfriend, whoever it is that they bring with them or identify as a support system for them. And we make sure that it's put forth by the treatment team that they may bring these issues up with whomever on the treatment team they wish. It's not that they have to bring it up with me. The only kind of ground rule that we've said is that if a patient brings up one of these issues with the treatment team member of their choice, and it really seems like the question at hand is up the alley of one of the other treatment team members, we have sort of told our patients that we're going to at least consult, if not bring that other person into the conversation in order to best answer their question. But the reason I'm involved as a physiotherapist is because if you look at most of the issues in these blue boxes, they go right up the alley of musculoskeletal health, but they all have an impact on sexual health. If you are in a lot of pain, if you have weakness, if you have lost motion in your joints, that is going to impact your ability to have an enjoyable sex life, undoubtedly. And so whatever other aspects there may be to sexual health, there is definitely a physical component to this that, as it turns out, as I've gotten more involved in this over the last 15 years, has really turned out to be, quite significant as far as patients and caregivers and other team members are concerned. If we look at what's available, if you go to the literature, and I'm going to give you a smattering of stuff, which is, as far as hemophilia specific, there's really not much. But even if you look at sexual health as far as how treatment teams deal with it in general, this is a study from about 10 years ago from the UK that looked at about a 10-year systematic review of literature at that point about how healthcare professionals talked about sex with their clients and why they don't do it. So they looked at a lit review of 10 years. They found about 19 different interconnected sort of themes that were coming out of the studies that they looked at. And if I group those 19 themes into 3 overall headings, it would be 1, that the staff at these clinics were afraid that they were opening a can of worms if they brought it up, that they might not then be able to follow through and deal with. 2, that they just didn't feel they had the time and the resources to deal with this kind of an issue. And thirdly, they were really worried about offending patients and people by bringing this up. And there was very marked discomfort, particularly as it came to patients who were of their opposite gender. And that speaks a lot to hemophilia. Most of the patients in this country, and I would venture I would bet a fair bit of money that all of the patients in this country, I mean, largely we're talking about male patients, and you've all had female nurses, probably almost your entire life. You've had primarily female nurses, and we're talking about a clinic with primarily male patients. And so there's a lot of the patient of the opposite gender to the treatment team members in hemophilia's case. People who were self-identified as a particular ethnic or religious group, sometimes the staff were uncomfortable bringing these types of issues up. Older patients, gay and lesbian patients, and people with intellectual disabilities was the other group that kind of bubbled up to the top in terms of the greatest level of discomfort. There was a study done in Norway as well, and I bring this up largely because it's very interesting when you look at the numbers. They surveyed about 650 different healthcare professionals of different stripes: nurses, physios, OTs, physicians, psychologists. They had a pretty good response rate. So of the sort of 300 or so responses they got, universal agreement: sexuality is very relevant. But 71% of those people, those healthcare professionals, said that they never raise it as a topic. And almost to exclusion, they said that it was the patient's responsibility to bring it up. And if you're a treatment team, abdicating that kind of responsibility about a topic that is so important is going to inevitably lead to a disconnect. And so if you think about these studies reflecting that attitudes of the professionals treating patients in these clinics is really central to these discussions coming up, how easy or difficult is it, and we all can relate to this from our own lives, to change your attitude towards something, right? So that immediately brings up, a discussion about different barriers to how we need to work together to solve this particular issue. But Canada has done a great job, and obviously, because so many of you on this call are very comfortable, and I'm happy to see that, bringing these topics up. And this was a letter to the editor from just a few years ago in Hemophilia. Comprehensive care is a term that is near and dear to the treatment teams in Canada and to the patient population in Canada. So when you title a letter to the editor that says there's a gap in comprehensive care, that's really eye-catching to a lot of us. And then when you identify that the gap was sexual health in men with hemophilia, it really sort of helped shine a spotlight on this issue. This is not meant to be any kind of shameless self-promotion here. This was a study that I did with some colleagues recently, just published a year and a half ago. And we looked at what was called the HERO study, Hemophilia experiences, results, and opportunities, which was a large quality of life psychosocial database that was collected in hemophilia patients. And we also looked at what was called the B Hero S study, so the bridging hero into solutions study. And what we were able to determine was that we saw a definite link between sexual health and sexual satisfaction and quality of life. I think we're the only study so far that have surveyed both men and women with hemophilia, because women's health issues, there's another whole dimension to this when it comes to women's health. And we were able to identify some pretty specific themes as to why people with hemophilia found this topic to be so important. And not least was the fact that there had been people who'd had bleeds before because of sex. There was a lot of fear about having a bleed because of sex. And pain came clearly and very distinctly through all of the noise surrounding some of the other issues, that pain was a huge barrier, and it's a libido killer. And, you know, in a relationship, when you've got one person who really is eager and one person who maybe their mind is willing, but their bodily pain just does not allow them to participate in that activity, it causes a very significant strain on relationships. And so what we really recommended was that a lot more investigation on a lot of different vectors was needed on this particular topic. And if we can't talk about this from a physical point of view, we're about the only ones that aren't talking about it. I mean, this is reality television from the United States a number of years ago, talking about how this gentleman, you know, was so excited that he shoved his girlfriend through the drywall at the end of their bed and gave her a concussion. Now, frankly, we're not usually dealing with concussions when we're talking musculoskeletal injury in hemophilia, but what we are often talking about is the iliopsoas muscle, which I showed you before, large muscle that holds a lot of blood in the pelvis. We see a lot of bleeds that are rebleeds into muscles that have had previous injuries, particularly in the thigh and in the calf. A lot of issues with target joints, ankles, elbows, sometimes the knees. And remember that bleeds can happen anywhere. I mean, any muscle or any joint that's overloaded is going to have the potential to bleed or have an injury. But the iliopsoas is kind of the front runner as far as musculoskeletal impacts of sexual health and hemophilia, musculoskeletal health and sexual health in a hemophilia patient are concerned. This is a muscle that acts largely as a flexor of the hip. It bends your hip, but it also activates your lower back. It assists with rotating your trunk. So it's involved in a lot of core level activities. It becomes very tight and inflexible when young men go from adolescence into adulthood or childhood into adolescence and are having a growth spurt, because our skeleton grows a lot faster than our muscles can catch up with. So you have a person whose bones are growing and their muscles become tight. And this used to be called growing pains once upon a time. And now we know that in places like the knee, that's what's called Osgood-Schlatter's disease, is a mismatch between the rate of growth of the skeleton and the ability of the soft tissue to catch up. So we know that teenagers tend to have tight iliopsoas muscles. And when you factor in a lot of time spent, what practically every one of us on this webinar is doing right now, which is sitting on a chair, I mean, does this look familiar? At every stage of life now, we are spending more and more time sitting on our rear ends, from very young ages to very old ages, whether we are a student that's learning, whether we're working and guilty of, as what I do, this gentleman on the bottom left, often I'm found at my desk having my lunch, and people are working later into their life. And so we're spending a lot of time seated, which really just exacerbates that loss of flexibility into the iliopsoas. And if you've spent a lot of time sitting and you have a flexibility problem in your iliopsoas, and then you try to get into the position that this gentleman is in, which is a pretty common one when you're engaged in sexual activity, you can see how there can be a bit of a difficulty in the transition between those two positions because they're complete opposites. I think it's important to draw some lines between intercourse and the potential for bleeding. Usually, I mean, this is an activity where the muscular contraction is driven by desire, it's driven by joy, it's driven by lust, it's driven by a lot of things, but it tends to be vigorous as opposed to a slowly controlled contraction quite frequently. Anybody who lives a more sedentary lifestyle, they're going to have that likelihood of a more shortened iliopsoas muscle with decreased flexibility. And a lot of the sexual positions that are the most common ones, they demand a lot from muscles in positions that are suboptimal for the muscle to try to generate that force. It's asking a muscle to do its job in a position that it was never really meant to do that job in. And so it's kind of maxing out, it's running close to the line. And whenever you're close to the line, if you just go that little bit extra, that's when you tend to overload the muscle and cause a bleed. I'm not big into profiling people, but if I were profiling the type of patient who I would say is most likely to be at risk of musculoskeletal bleeding from sexual activity, for sure, adolescents and young adults lead the pack in that sort of an endeavor. If I have a patient who's had a very quick, very significant growth spurt, I'm going to be watching them a little bit more carefully for this kind of an issue. If I know that I have patients that live a very sedentary life, spend a lot of time seated or not moving, those sorts of people maybe have a bit more of a high risk. I've got a lot of patients, and if you're on the webinar and you have hemophilia, you know how your body bleeds. And I've had a lot of patients over my career who are severe hemophiliacs who hardly ever have a joint bleed, but their muscles bleed regularly. So if you are a muscle bleeder, that also puts you at a higher category of risk for this type of injury. And for sure, if you have an established history of psoas bleeds, if you've got a history of having had this type of bleed in this muscle, that's really going to cause a sort of an increased risk overall for you developing an injury from sexual activity, or if you have hip flexion contractures from previous bleeds. But that's not the only kind of consideration we need to look at. We got a lot of patients who are not adolescents and young adults. And as we get older, although the propensity for bleeding decreases, your level of arthritis and the advancement of arthritis, that tends to increase. And a lot of things change, not only with your body, but with your relationship with the clinic. So you don't have the same dynamic between you and the nurse and the physio and the physician and the psychologist or social worker when you are 30 as you did when you were 20, or when you're 40 or 50 or 60. So the changing dynamics, the changes in our bodies, these really also have to be considered. And by the way, bleeds aren't the only kind of injury that we're talking about. I've seen, not only in my hemophilia clinic, but in my other orthopedic-based clinics, I've seen fractures that came from sexual activity. I had one gentleman who, it didn't come out till the very end of his treatment because he was embarrassed to say it to me. But what he had originally said was a slip and fall injury outside. When he was all better from his fractured wrist, he decided that was the right time to let me know that actually him and his wife had been trying something a bit different, and he'd lost his balance on the bed, fallen onto the floor, and broken his wrist. And I get it. I get why he didn't want to bring that up. He was 55 years old, right? And so he was a bit reticent to bring it up with me at the beginning. So a lot of people, I mean, there's a lot of reasons why people don't want to sort of let all of the details of how they got injured come to the fore right away. But this isn't only bleeds we're talking about. It's orthopedic injury, and people with hemophilia are just as susceptible to that as everybody else. I wanted to touch on this a little bit for folks within our community who have been living with HIV infection. It's not entirely clear that there's an extra risk for those people as far as musculoskeletal injury is concerned, but there are a few particular characteristics that I think are unique for that population. Now that we are able to study HIV through that lens as a chronic illness, there are really four main categories that would affect musculoskeletal function. The first, which is disseminated diseases, that's called, and we're talking about tumors and things like that. That I don't think is really where we're at with this conversation, but the last three, definitely. There are bone disorders that happen with long-term HIV infection, where there is a decrease in the mineralization of the bone for different reasons. There is HIV-related arthritis that exists. It's really targeted on the spine, but it can happen anywhere. And there are a lot of myopathies or muscle disorders that happen as a result of long-term HIV infection. And all of those things can certainly impact a person's ability to enjoy their sex life in a fulsome way, depending on what kinds of activities they like to participate in. And so really what this comes down to, as so much of it does, and that's why we talk about individualized treatment, is we need to do a needs analysis for each and every patient. Sexual health is an integral part of everybody's overall health, but what we really need to do is make sure that we do a case-by-case assessment of where do your greatest risks lie from all kinds of activities, including sexual health and sexual activity. The pain and the dysfunction that's associated with bleeding, the chronic pain that people get, as I said before, it absolutely staunches or kills your libido. And that alone, just making sure that we're properly addressing a patient's pain level can then in an indirect way unlock an improvement in their ability to enjoy their sexual health. And if we draw a line under those first 2 points, and if I ask you all now to consider over your lifetime, and this is for the patients with hemophilia, how much literature and how much talk have you heard around selecting a sport intelligently for you and for your body? And how much time by comparison, or how much resource allocation did you see towards making sure that you had the proper information for your sexual health? I mean, it's no contest right out of the gate. And yet I would wager that far more people engage far more regularly in sexual activity than will ever engage in organized sport. And yet the allocation of resources, from patient education materials to the amount of face time and discussion time it gets, I mean, it's absolutely a mismatch from day one. So asking patients if they've engaged in unusual physical activity, which is a question I no longer ask. I used to ask it early in my career. It never comes out of my mouth anymore. Were you doing anything unusual? I don't ask that anymore because sex isn't unusual. So people were giving me honest and legit answers, but I wasn't getting the information that I needed. We need to make sure that people with hemophilia understand and are on board with the fact that sexual activity is a legitimate potential cause of bleeding. Because if we don't make that connection for people on an individual basis, then the right people aren't going to take the right precautions. And I'm not talking about sexual sort of safe sex precautions. I'm talking about protecting their body physically so that they can participate in the activity that they want to do. So if we bring this conversation to where we are now in 2021, and this is a little bit tongue in cheek, and I've picked 2 things that are very sort of topical at the moment. So novel therapies, which in this country are a reality, thank goodness, and the pandemic. And I could say that novel therapies are great and the pandemic's bad. Or I could actually say that the pandemic is great and novel therapies are bad. And you might be thinking, well, what the hell is he talking about? Like, that doesn't make any sense. How can the novel therapies be bad? Interestingly, again, in the literature, this is a very fresh new study. It came out from the International Brazilian Journal of Urology. And they've done an initial study on the sexual practices and behaviors of people in the population during the pandemic. And I think that a lot of assumptions, and that's a word I used earlier, you would make a lot of assumptions, like if people have been locked up at home, they've probably been having sex like crazy because they had nothing else to do. Or if you were alone at home, you've probably been masturbating like crazy because there was nothing else to do. If you read this study, you'll find that a lot of the assumptions that you might think are obvious are actually the opposite in terms of how much sexual activity and what kinds of sexual activity people have been engaging in. So it's an interesting study. And because the pandemic has been with us for so long and is going to be with us for so long, I think that it's very legitimate to study its impact on people's sexual behavior. Novel therapies from a point of view of reducing bleeding are a huge win, okay? They are, but they're not universally available to all people with hemophilia across the world. They don't really address a lot of the women's health issues, sexual activity. And bear in mind, they don't make anything that has already happened to your joints go away. They don't restore your joints to showroom new conditions. So if you have a lot of arthritic change from previous bleeds or your life up till now, if you are on a novel therapy, that still means you have all of that arthritis. And we need to bear that in mind when it comes to discussions about sexual health and sexual activity. And the threat, I think, to dialogue is a real one. We've come from a place where this was never discussed at clinic, and now it is. But if you imagine that someone is having far less bleeds, perhaps far less of a what they perceive as a need to engage directly with their treatment team, then that means all conversations are going to be happening at a reduced frequency, sexual health included. So I do see perhaps a threat to open dialogue on this topic, just because treatment teams and patients might not be actually conversing with one another as frequently, because thankfully you're not bleeding as often. So, a number of years ago, and I want to at this point also, we have some folks from Bayer on the webinar, and as an industry partner, Bayer has been eager and willing and an industry leader in this country in terms of engaging in this topic for people with hemophilia, far further ahead and earlier than any other company who might be engaged in it now. And I think that really needs to be said, because they were eager to get involved at the ground level when nobody was talking about this, and it really was not popular. This is a resource that I produced with Boyan's help. He was part of the focus group that I used to generate this resource. And when I went to different pharmaceutical partners to sort of get some support to get this thing published, the only door that was open and wide open and eagerly thrown wide open came from Bayer. And I think that that's really important to state and to continue to state. This really started as a project that strictly was around Iliopsoas bleeding, and it really grew. It grew as I got involved and realized what amount of need there was. It grew to talk about bleed prevention. It talked about maintaining sexual health after an acute bleed, but also regaining your sexual health. If you have a lot of long-standing dysfunction and deformity from repeated bleeding episodes in the past, and if I haven't been able to convince you by now, I mean, if you look at this picture and you look at this elbow, I mean, look at the position the elbow is in. It's supporting this gentleman's body weight on an unstable surface. His arm is going to be tending to force itself into elbow extension. And if you have any synovitis in this elbow, it's going to get pinched by that forced extension in this position. If you look at his wrist needs a lot of strength, a lot of endurance, a lot of proprioception around that joint, and able to be able to maintain this position, again, on likely a soft, unstable surface for a period of time. And again, the stretch that's going on at his pelvis, in his hips, really increases the tension on the iliopsoas muscle. So there's musculoskeletal threats all over the place. And sometimes it's just as simple as picking a different position, because if you've got bad elbows, that position that I showed you just now, well, that's not good for you. But all of these positions are described in the book that I was able to produce. And all of these particular positions, as an example, probably work better for you if you have a really problematic elbow or problematic elbows. But you might not like this position, all of these positions, if you have problematic knees. So now, if you look at the three that I've highlighted here, as opposed to the one that I've left out where the gentleman's standing, if you have bad knees, maybe these positions work better for you. So part of this is really just about matching what you want to do to what your body is really able to comfortably do. And all of the positions are listed in two summary charts at the end of the book, one for heterosexual couples, one for homosexual couples, that really, in a very kind of graphic, and I mean that in the literal sense of the word, lay out for you where most of the stress is on joints and muscles in these various positions, just to be used as a guideline to help you kind of figure what might be the best position for you to try. There are a lot of threats to open dialogue. I'm not going to sugarcoat that. It's a very intimate subject, which is difficult for some people to talk about. There is still a situation in this country where we're talking largely about female nurses and largely about male patients, and sometimes that can be a bit of a barrier. It can also be a bit of a help in certain circumstances, but it can be a barrier. Cultural implications, possibly. If you think about standard products, and I'm not talking about the extended half-life products now so much, or certainly not the novel therapies, but the standard advice we gave on prophylaxis regimens completely countered when people would normally have sex and when they would be most protected. And so that was certainly a bit of a threat. We have to change the way we talk about prophylaxis regimens. There are some social-based elements, I would say, that revolve around sexual orientation, gender identity, religion, and a whole host of other things that can sometimes make the conversation a little bit more difficult to have. And then we really need to look at what the impact of novel therapies is going to be right across the board. We know that they reduce bleeding a lot, but there's a lot more to working with a hemophilia patient than just managing bleeds. And so not only the resource that I created, but there are other ones as well. And I've got references at the end, and the slides are going to be, I think, available to people after the fact. I think we're going to make sure that that's possible if people want to see them on their own to review them. But there are other resources, at least one other from the UK that is specific to hemophilia. And then the one that you see at the bottom right of the screen, Pleasurable. That really just is designed for people with multiple kinds of disabilities. And there's a lot of good information in both. And so with that, I will thank you for your attention. And I really do thank you for sort of logging on to this webinar and spending, what is valuable personal time with all of us as a group, because I think what it does speak to is how important many of us feel that this topic really is. So with that, I'm going to throw it back to Boyan, and I think we're going to go into the next part of the program.
Thank you so much for that, Greg. That was amazing. And I've heard you speak on a number of different occasions. And every time I do, I hear new information and new and interesting information coming out. Before we move on to the next section, I'd actually like to try something first, which is Amy and Chad, I would actually invite, before I introduce you officially, if you have any questions for Greg or are interested in any of that, of what he was saying in that presentation, that have a chance to ask him a question and have it answered, or we can move into our discussion. So I'll give you an opportunity to ask a question if you have it.
For me personally, I know that iliopsoas muscle is definitely an issue for me because I've been a soccer player my whole life, and now I'm trying to play golf, and that's the biggest problem I have. That would, stretching or what I could do for that would be, I would be interested in that.
So that's a great question, and it is a muscle that in so many people who have a bleeding disorder and people who don't, we do iliopsoas flexibility testing on even general populations, and it's almost always at a low level of flexibility because of the nature of life, and we spend so much time sitting. So if you think about what it does, it flexes your hip, so it bends your hip inward, like if you were bringing your knee towards your chest. And it side bends and rotates your lower back. And so the easiest way to stretch this muscle, you have to sort of secure one end of the muscle and move the other. And so usually the end that we secure is the spinal end, and you use the movement of your lower body to do the stretch. So the way that we test it and the way that we stretch it is if you are lying on a treatment table, and if you don't do this in a physio clinic, you would be sort of lying on your bed, and you'd want to have your butt cheeks right at the end of the bed, almost your bum kind of half on and half off the bed, but lying flat on your back. And what you do is you bring both knees in towards your chest, and then you keep one of them there, and you slowly let the other free leg lower down and straighten out. So it's kind of hanging almost in midair, or your foot's on the floor, but one leg is straight out and your other knee is in towards your chest. Can you visualize that?
Got it, yeah.
Yeah, if you can't, what I can do also, you can find pictures of this on all kinds of physio exercise databases, and I can send one through to Boyan and he can kind of post it with the slides. But it's a great question, because if I'm sitting here saying that the problem is tight iliopsoas, it's sort of disingenuous to do that and not make any kind of suggestion as to how you might work on it. But I will say that the caveat to that is you don't want to overstretch a muscle either, right? And you want to work within your level of flexibility. So for everybody on the call, if you have the same kind of question or wonderment that Chad just brought up, the best thing to do is to see your physio at your clinic and get like an actual flexibility assessment on yourself done, so that you can get specific stretching exercises for you. But yeah.
All right, thanks.
Wonderful, thanks for that. And Greg, I saw in the chat here, somebody brought up, would it be possible to see the patient resources again? So what I'm thinking, yeah, if you want to bring that up.
That one?
Yeah.
Yeah.
So
the one on top left is the one that I produced, and it's available. I think all the Canadian clinics have access to it, and they can they can talk to their clinic. If their clinic doesn't have copies, I get emails from the clinics all the time asking for more copies, and I work with Bayer to provide more copies. And I have a PDF. I have it electronically, and in fact, maybe Boyan, what I can do is also send you. I have the PDF of it in English and French. And so if that works best, what I'll do is forward both of those PDFs to you, and you can post them, make them downloadable. It's free access. It's not fettered at all. So maybe I'll do that, and that will help with that one on the top left. The one in the middle is from the UK. You'd have to contact the Hemophilia Society, which is their version of the CHS, to get access to it. I'm not sure that it's available as a PDF or if it's just a hard copy. And the pleasurable one, which it's in the references at the end of the slides. So when you post the slides for people, the reference is there, and they can also access that. But that one is free downloadable. If you just Google it, you can download it directly from the internet.
Wonderful. Thank you so much, Greg. Yeah, that would be a great way to handle it with your resource, and I'd be happy to also host that on our website as an available resource for people. Now, before we move on I wanted to throw in a question after hearing your presentation, which was, we talked a lot about, we saw a lot in your presentation about men with hemophilia and bleeding disorders, but I was also wondering specifically on the mechanical side, with women with either hemophilia or von Willebrand's, do you see a lot of the same physical manifestations or same target joints that you would in male hemophilia?
Yep. For women with type 3 von Willebrand's, absolutely. So men and women. So because people with type 3 von Willebrand's tend to bleed very much like a patient with severe hemophilia. So for sure, if we're talking specifically about women in von Willebrand's, I see the joint and muscle issues, particularly with people who have type 3, regardless of gender. For women with other forms of von Willebrand's, it doesn't tend to be quite so much the musculoskeletal bleeding as opposed to the mucosal type bleeding issues that they're having related to sexual activity. And for women with hemophilia, just again, one of the things that I've changed in my practice, me personally, I don't use the word carriers anymore. I describe what a lot of the world, I guess, would say is a female carrier as a woman with mild hemophilia, just because that's where the factor levels usually are. And so, if there is particularly vigorous activity or there has been some kind of a mishap, I'll say, I have seen women or other patients, I'll just say patients with mild hemophilia, regardless of gender, who've had some sexual activity related injuries, but I don't tend to see bleeds in those patients.
Wonderful. Thanks so much for that answer. At this point, I think we will move on so that we can get to the next section of the presentations. I'm seeing questions in the chat and in the Q&A, but I'll hold on to those until we move on. So without too much further ado, I'll pass it over first to Chad to introduce himself a bit. You can let us know a little bit about your story, and then we can get to the question period.
Okay. All right. Hi, everyone. I'm Chad White. Some people might have seen the email. I'm not 44. Thanks, Boyan. I'm 48. I'm from Windsor, Ontario. I'm a mild hemophiliac. Guess I was diagnosed when I was young, probably 3. I had a surgical procedure. What else? I'm a cancer survivor. I had stomach cancer. I had a full gastrectomy 10 years ago. I also represent the the hemophilia community who was infected by the tainted blood back in the day. You know, I've been HIV positive for around roughly 33 to 35 years, something like that. Very healthy. And, you know, my big thing, I guess, these days is giving back, because my mental health because of that hasn't been very, very good. And I think in hemophilia, one of the biggest things in any chronic disease where you're constantly in pain, mental health becomes an issue. So for me, and my mental health, giving back is a big thing for me. So like I'm on the board for Hemophilia Ontario. I'm on the board for Positive Pathways, which formerly is AIDS Windsor. And I'm currently pursuing the board of Ontario AIDS Network, OAN. As for, I'm married. I have 4 wonderful children. I have triplets that are 18. I have an older son who's 21. I work at Ford Motor Company for 26 years, and I'm an avid, I've been a soccer player my whole life. Hence the reason why they call me the Tin Man now, because I'm pretty stiff. But yeah, that's me in a nutshell, really. Look forward to participating tonight. And it's all yours, Amy.
Okay, my name is Amy Griffith. Personally, I am an educator. I have been a kindergarten teacher for 7 years. So I have a very distinct connection with youth, particularly when it comes to education, fellowship opportunity, and legacy planning. And when it comes into Hemophilia Ontario, I've worn many hats. I've been on the board of directors. I'm recently back on. I was a Code Rouge ambassador for Ontario in the first original Code Rouge program, as well as leading the portfolio for women and youth within the board. I am co-chair with Natalie, another staff member with Hemophilia Ontario on our women's committee, which is making some really great headway. I'm very happy to say. I'm also happy to see that there are women on the call. I'm very happy to see that we have already mentioned women within the webinar. I'm coming in with a completely different perspective, and I think that I'm hoping that someone will get something out of that. I live with BWD2A, which sometimes will teeter into severe and sometimes will teeter in the complete opposite direction. And personally, I live with my partner, Joe. We have no children yet. A big part of that is because of my career, and I can't decide whether I want children because I'm surrounded by 30 of them every day. And yeah, I'm here to, offer another side of things, another gendered side, another diagnostic side, as well as sort of the social advocacy as far as women and how they bleed. It's very different within society and within our organization. I'm happy to see that there's headway coming through, but we have a long way to go. So I'm looking forward to having that conversation tonight as well.
Wonderful. Thank you so much for those intros. And I'm going to dive right in here. So let's start with not an easy one, but a basic one. So I'll start with you, Chad. Do you feel, especially now in light of Greg's presentation, I'd like to add, do you feel like your bleeding disorder impacts your sexual health?
I guess when we talked the other day, I didn't think it really did, but now, it's like, you have any questions and you think of them later on. I think nowadays, definitely if, I had this problem the other day where with COVID not going to the gym, I've been going to the gym lately, and I've been feeling very sore and I guess not very attractive. So, when you're crawling around the house. So yeah, it's affected lately. And anytime when I really exert myself, it's, there's no sex drive there when you're in pain. Anytime you're in pain, that's for sure.
Thank you. That's a great point. And the impact of pain, I think, is something that we don't look at enough, especially in sensitive areas like that. So really quick, I'll throw it over to Amy with the same question.
Do you mind repeating? I missed the first part of that.
Oh, yeah, sure, no problem. Basically, do you feel like your bleeding disorder impacts your sexual health? And I mean, does Greg's presentation also add a different dimension to that?
Yeah, absolutely. So for me in particular, and I think there may be women that can attest to this, and I want to start by saying being a woman with a bleeding disorder is a really big spectrum. So there are different types of, like, I like that we're taking away the term carrier. So there's the mild hemophiliacs, there's those who are diagnosed with hemophilia, there's rare, there's severe, there's platelet disorder, and there's VWD. And then within them, there's also the societal understanding of the way women bleed is really not something that's ever talked about. So it's all still very taboo. So that spectrum, I really can only speak from my own experience. And any woman that you speak to is going to give you a completely different conversation, a completely different diagnosis. I'd argue to say even further and even more diverse when we talk about our male counterparts, because we play so many different roles and have so many different hats, as well being that we're caregivers for a lot of people who also live with inherited bleeding disorders. So there's that to consider. So when I speak solely for myself. For me, I have found that a lot of my, yes, absolutely, it impacts my sexual health. I would say less so now that I've grown. I would say my younger years, absolutely. I found that it was more a social, emotional, and mental health as opposed to my physical health. And I'm sure we'll get into this a little bit more in depth later. But yes, it directly impacted partners that I had. It impacted experiences that I had. It impacted the level of experience I allowed myself to have because of the way I bleed, and how it's different and how it's viewed by people within and outside of this community. So yeah, absolutely, without a doubt, that pain comes from a very different place. And it's something that has really evolved as I've gotten older and smarter and more experienced. And, but yeah, that journey was a long one, and it resonates with you in a very different way than physical pain does.
Great point. And thank you for sharing that. Now, the next question I'll move on to is, and I'll start with you, Amy, now. Do you have to think about or plan around your bleeding disorder as it relates to your sexual health? And I think it would be helpful to answer both as it pertains now and also what you've referenced there, your younger self.
Not so much now, I'm happy to say. I have been with my partner now for a few years. We've had an opportunity to get to know and trust one another. We've had an opportunity to really, I find sexual health really thrives based on the relationship that you have, which sounds obvious, but you could be really close to your partner and not talk about these sorts of things, whether it be your bleeding disorder, whether it be your pleasure, whether it be your sexual health, whether it be your preferences. Sometimes, as Greg was saying, these are things that don't come up, regardless of your healthcare practitioner, but sometimes with your partner. So now that I'm in a position now where I am very open and I'm able to discuss these sorts of things, for sure. Like I find there's less preparation. I can be more spontaneous. I don't feel the need to, protect myself from previous experiences. I'm not afraid of them happening. I've already had that dialogue. I don't have to offer explanation. Whereas in my younger self, it was completely the opposite. So, there were moments where I didn't let myself fully experience a sexual experience because I was afraid of what outcome could have been. So we talk about like rigorous sex, there's bleeding involved with that. And with women in particular, everyone sort of has that college perspective of, a girl will bleed, right? It's a completely different experience for a woman with a bleeding disorder. And the anxiety that comes along with that, and the level of blood and the amount of, the lack of education that there is out there with your healthcare provider, because again, I find with women, because these are natural experiences, so periods are natural experiences, bleeding, while you're having sex is a natural experience. We don't think to talk about it in a way that prepares us because it's going to happen inevitably, right? So I found that as I navigated this at the beginning, I had a lot of experiences that were a bit traumatic, where there had been a lot of bleeding and I hadn't known how to explain it. And I didn't know if I should be worried. And I didn't know if, and I had to have those conversations with people that, partners or casual acquaintances that I didn't actually intend on having a relationship with, that, and then those affected my experiences as I moved on. So I would say, short answer, when I was younger, absolutely affected me way more preparation. Nowadays, I've learned so much. I've come a long way, much more vocal about it than I was, more confident than I was as a younger person. And I'm with a partner that I've put in that time and I've put in that experience so that, I don't have to worry in the same way that I used to.
Yeah, makes perfect sense. And yeah, that's very interesting. Thanks for your answer. And I'll move it now to Chad. And I wanted to ask you, you'd referenced your HIV diagnosis, and I wanted to ask specifically, what was it like when you were younger, when you just got that diagnosis, versus how it is now?
Okay, I was going to throw that in there. Well, I'll start with the hemophilia part. Like, I guess hemophilia more affects my sexual health now that I'm older and I'm less limber and those kind of things that we discussed earlier. As for my HIV, obviously I'm married. I'm undetectable. It's not a secret to my wife, so that's not an issue. But yes, it was a huge issue as a teen, as a young guy in high school, because basically when I found out I was HIV positive, I was 15. I was going into grade 9. The last thing I wanted anybody, because back then, the stigma was huge. It was a gay man's disease, and that's the last thing I wanted to be known as in high school as a grade 9. So basically, I was, I threw myself into sports, and I was the best athlete at the school in every sport, which comes with attention, which in turn was a problem, because at that point, I knew that I had to tell people before I had sex, and high school is high school. You tell one person one thing, everybody's going to know. So as a popular kid in high school, I was really defensive, and I didn't tell anybody, or I made up stories that yes, I had sex when I didn't, because I didn't want anybody to know. And the toughest part for me in my sexual experiences back then were, I only trusted 2 people at that one in my young age, and that's it. And I told them, so that was the most difficult part about it. Where now technically, if I was single, I wouldn't have to tell anybody because I'm undetectable. But really, if you're going to have a relationship with someone, you would have to. In my situation, you're not going to tell them after the fact. That would be kind of awkward.
Yeah, it absolutely would be. One follow-up question not follow-up question, I'd first like just to ask if you could explain to the audience what undetectable means. A lot of people who are around during the tainted blood tragedy will know what you mean, but it's not a very well-known thing outside of the community. So if you could give them a short explanation of that.
Well, undetectable is basically 50 parts per million. I guess in your blood, your levels are that low where it's really, they call it undetectable, and you can't transmit it sexually. That's the whole you equals you campaign, and actually they've advocated where it's not a criminal offense anymore. If you're undetectable and you have sex with somebody, you don't have to tell them. You're not obligated, which was really the huge thing when I was a kid, is that was actually the thing grilled in my head. I was more paranoid about infecting someone and then going to jail or something, even if I told them. Like that was a big thing back then when I was younger.
Yeah, and that's wild too, that it was something that was criminalized. And I'd imagine that it wasn't explained to you. I don't know how it was, but was it empathetically explained to you as something you'll go to jail if you don't disclose your status?
Not really like that. Like a lot of the HIV part really wasn't explained to me by my nurse. Like I felt like it was one of those memories that yes, you have it, and then it's kind of a blank. What happened after? Nothing, because truly, when I look back at it, I needed to talk to somebody about it, because I wouldn't be the angry person that I've been for a long time because of it. But my parents really, not that they said I would go to jail, but they really grilled it into me that which it was tough love, but it was wise at the time, because if I was a regular teenager like my buddies and didn't think of what I was doing, I could have been in deep trouble back then.
Yeah, makes perfect sense. And two, I think that they were probably just trying to do their best to protect you too, but I imagine that's a lot to put on the shoulders of a teenager.
Yeah, because they knew very little as well as I did. They just, I guess, I didn't want anybody to know, and I don't know this. I could say they probably didn't want too many people to know either. So
yeah,
the stigmas were huge, so they didn't want another parent to know, and somebody finds out, and then basically my high school career would have been very rough.
Yeah,
in my opinion.
Totally understandable. Thank you so much for answering that so openly. I'll move on now and ask Amy. Let's ask a question like this. What is something you wish that other people knew or appreciated about your bleeding disorder, or the impact that your bleeding disorder might have on you and your sexual health, if you could have had that?
I think in general, just that it has an effect. I still think it's a super upsetting fact that that's still something in and out of the medical community, in our social advocacy community, that it's just assumed. Again, like I said, it comes back to predominantly many women will experience periods. They will experience sex. And when they do that, certain bodily functions, sorry, it's been a long day teaching in person, they'll happen regardless of whether or not you have a bleeding disorder or not. So because of that, there's this line that's drawn. I've heard this quite often and had to educate a number of people when they say, oh, well, but when you have your period, it's not like getting a cut. So it's not the same. Like, you won't bleed more. And I'm like, that's a very dangerous misconception, because I can tell you when my next bleed's going to happen, how long it's going to be, and how much it's going to affect my life. Whereas treatment is so great nowadays that some people who are diagnosed don't ever have a bleed, or they haven't yet, especially youth. They're able to go on prophylaxis and pre-treat in order to avoid a lot of these injuries and proactively increase their quality of life, which is incredible. Whereas for women, it's a very different experience. But where that line gets blurred is that just because it's a natural thing that happens to women, it doesn't mean that it's not a massive effect on our lifestyle. So I think the biggest thing I'd want people to know is that, like, it has an effect. And, we need to get to a place where we have to stop justifying that or getting people to understand that. And that's sort of the goal on as many of these talks as we do. That's the number one thing I'd want people to know in the community, is just that, this is a massive part of how I bleed, and I don't want to have to continue to explain why. And that's a huge one. As far as in my social community, I've always just asked that people respect and understand that I'm the expert. And I think that people often lose sight of that because they're trying to be so helpful, so they'll, you never want to turn down someone asking a question or trying to educate themselves. But you do get to, this is not a sex related example, but nosebleeds is a huge one. You know, we've all like, tilt your head back, hold up here, put the ice here. It's like, no, I don't want to do any of that. Please just trust me, you know? So, and I think sometimes it translates into our medical community. They're so incredible, and we would be in a horrible place without all of our hematologists and our doctors, but it's a lived experience. And the patient experience is really irreplaceable as far as, so when it comes to collecting data and collecting lived experiences and relating that directly to somebody's lifestyle. You know, I'm really fortunate to be a part of a women's clinic, and we've started having those conversations where I fill out surveys that directly relate my quality of life to my medical records and draw exact connections. Like, oh, you were too tired to get out of bed. That's probably because you were bleeding 7 days a week and, you know, weren't on any type of medical intervention of any kind. So I think it's twofold. It's getting the understanding that it has the effect, and it will affect your sexual health, because overall how you feel, you know, as Chad was saying with pain, overall how you feel, and like anemia is huge in the women population, and it's exhausting on top of working and having kids and being a primary caregiver and having responsibilities, and then essentially having iron levels that are in the single digits, you know, and it's all in relation. And the more we understand that, and the more we listen to patient experience, the greater those connections are going to be, and the less advocacy that will have to happen over time. So yeah, I'd say those are the two big ones for me. There's a question in the Q&A about my younger self. I'll come back to that one later, because I think that deserves its own attention.
Great, yeah, absolutely. And yeah, we will soon be starting to get to answering some of the Q&A bits here in that section and start peppering them in, because yeah, we want to make sure we get to those. So Chad, I'll throw that same one over to you. What would it be like, what would you like for people who don't have a bleeding disorder in your life to know about a bleeding disorder, if anything, and how that affects you?
Well, I would like, I guess the biggest thing too is, you know, sometimes like people in my life, especially my younger life, they see me as a, you know, as a good athlete. I'm always the hardest worker and everything else, but nobody ever seen me at home, you know, afterwards when I felt terrible. You know, I'm icing my joints and things like that. And, you know, a lot of things, you know, cuts, I can't die from a paper cut, or, you know, things, stupid things like that when I was younger. I remember those. But I think I like to tell people, you know, just because I can carry it doesn't mean it's not heavy. So that's one of those things. Just because I look fine doesn't mean I'm not in pain. Doesn't mean I technically don't have an active bleed at the moment, which, you know, happens a lot when you're as active as I am. And back then, especially, there was no, I didn't take prophylaxis back then. So I would, you know, because I was mild, they only gave it to me as needed. And, you know, I bled like a severe because I was so active. So I needed it a lot. So a lot of times the hassle of actually getting it, I just didn't do it. And I suffered instead, and, you know, put on a happy face, where I guess a lot of times people don't understand the suffering, really, the behind the scenes, that, you know, you don't want to be that guy who's always complaining about something. Oh, my back hurts, my knees hurt. You know, that's a lot of things that if I could tell those guys, you know, especially my soccer buddies, they always expect me to be there, be going at it hard, or, you know, what happened today? Why were you were a little sluggish today? Well, you know, truly, you know, I felt terrible. You know, we just played 2 days ago or whatever it was, you know. And when I was younger, sitting in the ER for a couple hours to get factor wasn't at the top of my list. So
Yeah, thanks for that. Thanks for that answer. And yeah, it's always going to be a game of catch up too, right, with friends. The way that I've experienced it anyways is like, I'm 30 years now, 30 years old now, and I've had chronic pain for probably 8. And I'm just hearing my friends now start to feel like, oh, I've got a little pain in my back. I got a little bit of pain in my knee. And they're very, they're very confused by it, and they don't know why it's happening to them. It's interesting to watch.
I gave one of my friends and his mom a crash course when I was 7, and I split my head open. I was bleeding everywhere. So they got a crash course in hemophilia, like, so.
Yeah, that'll happen.
I didn't have to explain it to him anymore after that.
All right, so let's move on now. I want to make sure that we get to some of these Q&A questions. So I'm going to pepper them in now, and if we have more time for some of the questions I've prepared, that'll be great. Yeah, I'll open it up here. And so we've got one here that says, Amy, thank you. How would you explain bleeding to your younger self? What would you say to young females who are currently exploring sexual activity?
Hoo-wee, what a question. I think the number one thing is, so it's twofold. So we got the bleeding side and we've got the sexual health side. So on the bleeding side, I would say, actually, this one goes for both. If it doesn't feel right, it's not. So the more appointments you go to, the more you learn. Sometimes you'll get a gut feeling that maybe you haven't got the answer that you needed, or you weren't heard, or you didn't feel that you got the outcome you were expecting. I experienced this a lot, and it was never to the fault of my hemophilia clinic. I was really lucky to have an incredible team when I was an adolescent all the way up to, now. The difference again, and like Greg was saying, I had growing up through my sort of informative bleeding years, which was when I was starting my period, I was still in pediatric care. I had a male hematologist, and he's like, talk to me about your period. And I was like, absolutely not. I don't want to do that. So, but it was a massive part of my healthcare. And at the time I didn't know that. And it's twofold, right? It's women who do not want to talk about their period because saying the word period makes them uncomfortable because they know it makes other people uncomfortable. You see the commercials and you see, it's nice that it's all starting to come out now, people are talking about the blue liquid in the commercials and, and how silly and ridiculous it is and how it's creating a really uninformed youth base, especially, and how it's important that we start having those conversations. But I would say to my younger bleeding self, collect the data. Data always speaks. Anyone who won't listen, and it will happen, whether you're in an ER or whether you're meeting a new clinic team or whether you're in an area, there are different areas in Canada that are not quite advanced to that point yet, where we're talking about gender specific care. We're still not quite there yet. But numbers and data always talks. Numbers don't lie. So whether that be that you're tracking using an app, bring those to your appointments. It just helps articulate and answer some of those questions. I remember when I was younger, I didn't exactly know what they were asking me. I wasn't giving them the answers that they were looking for, on top of the fact that I was completely mortified to be doing it. At the end of the day, they weren't understanding what was really happening, and my healthcare was suffering because of it. So that's the number one way that I bleed. Not only that, I was kind of one in a million as far as being a part of the Hemophilia Ontario community, as far as women went. So it's really important to find people who have lived experiences like yourself. It's really humanizing, and it's really grounding and reassuring to know that you really aren't experiencing it on your own. And I'm super happy that there are more women involved and are willing to come out and talk and share their experiences more candidly, because there is a lot of comfort in that. When it comes to sexual experiences, don't compromise what you're feeling for your partner. I think this is really common in women in general. I think it's something that we are naturally wanting to please. We're naturally wanting to perform. We're naturally wanting to not rock the boat or be embarrassed or make our partner potentially feel less than because of our experience. And I think if there's anything that I wish I'd known earlier, and something I'd really want to preach to a younger youth group, it's that you're a part of this conversation as well. You're a part of this experience too, and that's really important and it matters. One person does not outweigh the other. I know there's lots of, I'm looking through all these Q&As and I'm truly amazed at how female focused this conversation is. And I'm really floored by that. And I'm really encouraged by that. And there's lots of conversations about positions, OB-GYN. There's lots of conversations here about communication and experience. So I don't want to take up too much time because I do want an opportunity to get through these. But yeah, I would say, my biggest message is, and we're trying to communicate this to women in these webinars and by having this women's committee, your healthcare is important. And I think that women are starting to realize that because they're starting to see themselves and hear themselves and see themselves represented within this community. And you don't have to compromise anymore. Like there's room for everybody. And young people especially need to know that. Because when you're going through a sexual experience, you need to understand the role that you play and the decisions you make are valid and they need to be understood and respected. And the more positive experiences you have, the more confident you'll be moving forward. And maybe it won't take until you're in your 30s, like I am, to have the confidence to be like, I actually enjoy sex because it's something that I don't have to be in my head with all of the time thinking about the other person. Like I'm here too.
Thanks so much for that, Amy. We've got some questions here rising to the top with likes. So one question here, I think Greg is who I'm going to aim at. Anyone who knows can also chip in on this one. And I'll say that just to preface, I don't know the answer on this, but I will be looking into it after the conversation and be emailing everybody who's participating in the webinar if I find anything useful. So thank you for the presentations. I was wondering whether there are any good patient education resources for adolescents in terms of sexual health. Are there any specific patient education resources for females with bleeding issues?
None that I'm aware of. As far as, for sure, if we're talking about with respect to bleeding disorders, and I'm going to put that right out there at the beginning with the spectrum of healthcare teams and issues that are out there. There may.
Sorry.
Sex practices.
Greg, your audio just cut out for a little bit there. If you could just repeat that last whole part.
I really doubt that there are any specific resources for sure adolescent women with respect to the kinds of issues we're talking about right now. I mean, the broad strokes application of things like safer sex practices, of course. I mean, that's applicable to everybody. So those kinds of resources exist, but I am not aware of any, and certainly there are none within bleeding disorders that are targeted particularly at young women.
Okay, thank you. I'll open it up to the panel too. If you have any, if you know of any, you can shake your head no if not.
I do not. But again, I think I've already kind of said my piece on the fact that this is still something that we think we're further ahead on, that maybe we still have some work to do. And it's great. These conversations are happening. At this point, that's all I think all of us could ask for. I can say that my personal vision for this and why I decided to be involved is this conversation about sexual health is well overdue. But on top of that, I would like to see a position and a place where we roll this out to target youth and adolescents in particular. These conversations really need to happen with them as well, because that's predominantly where we're seeing, where we would see risky behavior, including sexual health. So my hope is when that time comes, we'll be able to have a conversation just like this one that's targeted to that age group, and that those resources will start to catch up on both sides, male and female, but particularly for female, absolutely.
Thanks, Amy. So one that's been getting a lot of thumbs up here, I'm going to lob right in like a grenade, though I don't know who is going to be able to speak to it best. But in regards to anal sex, regardless of orientation, are there safe ways to prevent bleeding or reduce the risk of mucosal membrane bleeding?
Yes, I mean there are, and the key point here is that it's regardless of gender, but you have to remember that if you are going to engage in anal sex, one, you need a lot of lubricant. too, you need to make sure that this is something that you have prepared for. This is not, it's like the sphincter around the anus is like any other muscle. It can stretch, but it is not used to stretching in the way that a lot of people might have it stretched when they engage in anal sex. And so you need to prepare. If you have a very well-endowed partner, if you're using sex toys that you're going to insert anally, you need to make sure that you have a lot of lubricant, that you go slowly, that you let the sphincter take time to adjust to the size of what is being used for penetration. And the force and how vigorously it is performed, again, has to match what your experience level with the activity is. And you need to prepare, really, is the safest way to do it.
Thanks so much for that, Greg. I think that's pretty comprehensive. I'll open it up to anybody else who wants to speak on it in the panel, and you can, as before, shake your head no if you'd like. Got it. All right. I just want to ask Kaylee for a second. I don't want to ask anybody to stay too much longer, since we did say we'd have a wrap-up time at 8, but we have some really great questions here. So I'm wondering if people might be able to stay 5 to 10 minutes.
Everything's good on our end.
Yeah, we're good.
Wonderful, thank you. So next question we've got here is, so kudos for surveying women, resex, and health. In terms of risks and issues with sex, the presentation has only covered men's positions, joints, muscles. Could you speak to women's positions, please? As a woman with severe von Willebrands, I do bleed into muscles and sometimes joints. For example, the safe position for a man on his back might be risky for the woman who is on her knees on top.
Right. So I'll start with that. And with the resource that I created those years ago, and Boyan, you remember you were part of it. You know, we identified it as, we tried to make sure that we identified it as what it was, which was a resource for protecting joints and muscles related to injury from sexual activity. But what I tried to incorporate, and there really is, I don't think, any way to incorporate all the answers for every population into one resource, but all of those positions, when you see them in the book, there's a description of the risk for the penetrating partner and a description of the risks for the partner being penetrated, if we're talking about penetrative sex, which is only one activity. I mean, I think that's the other thing we need to clarify, is that it's easy to whitewash this topic in lots of ways. One of those being that sexuality and sexual activity is intercourse, which it isn't. That's part of it, but that's not all it is. One of the other questions that I saw listed was about when is it safe to have sex after a major surgery like an arthroplasty. The actual legitimate answer to that question is as soon as you're back in your hospital room from the operation. Like, in terms of safety, we can make it safe for you as soon as you're back from the surgery. It just depends on what it is you want to do as far as sexual activity is concerned. But we have a tendency, I think, to equate sex with penetrative intercourse, and that's not all that it is. But the resource that I created tries to cover some of that information by kind of just breaking it down to, and I've talked about it, I think, maybe in this presentation about men. The pictures show a man and a woman. This was a resource created better part of 10 years ago. We were trying to maintain a sensitivity to what a lot of people would find palatable and that they would respond to. And I'm not going to lie about that. We decided to picture heterosexual couples. We did. But we tried to make sure in the book that we made specific mention of the fact that this is not just a resource for heterosexual couples. And so if you look at the position that the woman is in that book that I created, if we're talking about just that one resource, whether that's a female or a male, the risk of injury to the partner in that position is described for each of the positions listed.
Thanks, Greg. Yeah, I remember at the time when I was part of that focus group too, and it was edgy for the time. It was interesting because the prevailing mood in that room, I was an 18-year-old, so I was pretty gung-ho, but the prevailing mood in that room was pretty conservative. So it was a step on the way.
Yeah, and I think to echo what Amy's been saying, I mean, I've been working with the folks from Bayer for it seems like a long time now, and we've been continually interrupted, and most recently by COVID, about updating that resource, because that resource it's gone around the world now, and I get requests for copies of it from all over the place. And I think, interestingly, talking about assumptions again, the first country outside of Canada that asked for access to it was Qatar. And I think that people would be surprised, perhaps, that a largely Muslim conservative country would be the first country asking for access for that for their patients. And a lot of those requests were coming from moms for their sons. So I think we make a lot of assumptions, and a lot of times those assumptions are entirely false. But by far, the biggest request that I've had in terms of how to update that resource and the information that needs to be included is information specific to women.
Thanks so much. Great, I muted myself there before putting up the question. All right, so the next question we have is kind of a general one, but we'll try to address it. Do you know what percentage of bleeding disorders clinics in Canada have a gynecologist as part of the comprehensive team? I couldn't speak to a percentage. Is that a 3%, Amy, that you're saying?
There's 3 centers that I know of.
3 centers, yeah.
The reason I give you that number again, so this is actually a huge one for me. It's a hill I will literally die on. So comprehensive care document was due for update, and it actually has happened recently. And one of the biggest conversations I would have at the board table is that OBGYN was not included in the comprehensive care team directly. They were considered on a referral basis. And the danger with that is typically you'll get referred until something is wrong. And again, we're proactively preparing a woman for something that is going to happen, whether they like it or not. So it should be something that's proactively a part of their healthcare. So when I say that they are part of the clinic, not directly. So for example, the reason I say 3 is that there are 3 established women's clinics in Canada. There's one in Quebec and there's 2 in Ontario, one in Kingston and one in Toronto. For all the women on the call, if you've not been on any of the webinars and you don't already know, you can be followed at a women's clinic if you're willing to travel. It's really important that you know that. Again, we have incredible hematologists, but there is something about being in a women's clinic that will be different. You're also connected to prenatal, postnatal, and OBGYN. They're not included in-house. But you are given that direct connection. So for example, in Toronto, when you're at Dr. Scholzberg's clinic, you have a direct connection to Wilhelmina Mephi, who is very conveniently located a block down the street. So that proximity is actually quite close. But as far as a comprehensive care document, it is still, it's included in the literature now, but it is still a bit separated as far as you go to your clinic visit and you see physio, social work, that sort of core team. OBGYN, though now in comprehensive care, which I'm really thrilled to see as far as it's documented, is still, I want to be honest with the reality, it's still not as included physically in reality as it's sort of presented. So as far as answering the question, there are 3 established clinics that have the OBGYN connected directly by you going to that clinic. The rest, they're there, but they're not as physically close as the rest of your core team would be.
Can you name them really quickly, just because we've got that question in the comments?
Yeah, so in Ontario, we have one in Kingston, that's Dr. Paul James. And then we have one in Toronto, which is Dr. Michelle Scholzberg. And then in Quebec, we have Rochelle Winnikoff. And I'm hoping they're popping up other places, and I just don't know of them, but those are the 3 that I'm currently aware of. They are also the big providers on women's research. If you're looking for research, they're always doing therapy. I know Dr. James is currently doing one on, it's labeled as carriers, but her study is particularly in that area. And Dr. Rochelle Winnikoff was a big part of the reason that Code Rouge got off the ground. So they're very big pillars as far as women's care goes.
Thank you. And I'll also add that Winnipeg is on the way to one, hopefully soon.
Good.
Another question we've got here, and I think you touched on this a little bit, Greg, but no one has raised the issue of the impact on sexual health for those who have been through joint fusion / replacement, both men and women. Wonder if Greig has spoken to patients about that, has any insight, or if he has given advice on when it's safe, quote, to resume sex after a major surgery.
I do discuss it with all of my patients who are going to have a planned surgery like an arthroplasty or fusion. I bring it up and ask them if it's something that they would like to discuss as part of their pre-op and then post-operative care. Some do, some don't, but the short answer to the question, as I say, is it's safe to have sex right after the operation. Now, whether your pain will allow you to enjoy it or what type of sex you want to have, that's different. But there are a lot of ways to provide pleasure and receive pleasure. And it's not just penetrative intercourse. There's manual stimulation, there's oral stimulation, there's lots of different things that fall within this space. And so I think really what needs to be discussed is a proper pain management program after the surgery, whether or not there are particular types of activity or positions for the joint being operated on that are going to be potentially disruptive to the surgery that was performed. But that's all very easy to talk about beforehand. So the short answer to the question is you can have sex right after surgery if you're up for it and you on your own, or you and your partner, but you might need to do a little bit of pre-planning as to how you're going to enjoy each other or how you're going to enjoy yourself before you have the surgery, because it's not the easiest thing to figure out once the surgery's already been done. I mean, it's like anything. If you plan for it in advance, you're gonna be more successful with it when it comes time to really try it out. And then I just want to, as a final comment, I just want to say, because I think that what we've been talking about is extremely important, and we're talking about various groups. There's been so much good information that's come out tonight about women's health, and we're talking about resources for young people and adolescents. And I just want to stress that sexual health and sexuality and enjoyment and having a sex life is something that it's part of every stage of life. And so really, I want to see resources for everybody. I want there to be resources for people who are older adults. I want there to be resources for people who are youths, men, women, for all kinds of categories of people. I think what we really need to do is make sure that we leave nobody out of this conversation, because that's the danger, is that that's the assumption, right? Oh, well, you're 65, so you're not interested in sex anymore, so we're not going to discuss that at your clinic visit. And that's just not on. That's not in any way, shape, or form the right way to approach this. And so, I want to make sure that anybody listening to the webinar who might watch it knows that this is a discussion for everybody, and it's something that anyone should be able to bring up with the people who they think might be able to help them if there's an unmet need.
Very well put. I 100% agree. We've got a couple more, we're quickly running out of time. I'm just going to answer a couple questions that I can cover here. One was, what is the percent to be diagnostic to von Willebrand? I believe that the question is what percentage of people are diagnosed von Willebrand, or what number of people are affected. So the number of people affected could be as high as 1% of the population. It is the most common bleeding disorder, but about almost 90% roughly have not been diagnosed, it's thought. So despite being a huge percentage of the population, it's a very underserved portion of the population that is only now starting to be served better. So I'll answer that. And then I had one that was actually directed to me on a different note about sexual health, and in parentheses, and Boyan, you might actually know best, and that generally is the right assumption to make, is still a prohibition against partners of clotting factor users against donating blood. So basically, this is a reference to the blood donation questionnaire that you'll get if you will go to donate blood. It's a if you're engaging in sexual activity with somebody who uses clotting factor concentrates, you were ineligible for a long time to donate blood. This is still the case because of the connection with the tainted blood tragedy. It remains the case that if you have sexual activity with a person with a bleeding disorder, you are not able to donate blood. All right, so one person is asking you, Greig, to put the libido page back up. If you have time to find that, you could throw it up, but if not, we may, that one may have to go unanswered. And then the last question we've got here, Amy, do you have any advice for when telling your sex partner about your bleeding disorder makes them afraid they will hurt you, which makes them hesitate to engage?
Yeah, absolutely. I think, again, as many experiences that women may have that are not ideal, or that were not where their pleasure was put first, or where their needs were not considered, or they weren't like an active participant. Unfortunately, I think that happens, especially when you're younger, a bit more often than maybe men know. So for me, I just think that for me, it's always been about confidence. The more confident you are having the conversation, the more confident they're going to feel. So I always have this conversation. It relates to anything to do with women's health, really, because it's not something that people are comfortable talking about. And it's not something that we openly talk about, whether it be periods, whether it be sex, whether it be pleasure, whether it be female orgasm, like whatever it is. People are less willing to talk about that for females as they are for males generally. Luckily, though, that is changing, and I'm really happy to hear that and see that. And there's a lot of really good sort of empowerment, particularly on social media, literature, social media accounts, artists, creators. They're coming up with that information for women to help them have those conversations. For me personally, I did have a partner I was with for quite some time where I was noticing I was having the most bleeding, and I could tell that it was making them quite nervous. And I would have this conversation with them. At the beginning, I was so embarrassed that I almost kind of brushed it off, like, yeah, okay, it's fine, whatever, like, don't worry about it. And I realized that was actually making it worse, because they could tell, they could see straight through me that something was wrong and I wasn't talking about it. I found that the more confident I was talking about it, the more it normalized the conversation, the more that neither of us had to worry about it. So a lot of the time it's coming from a protection side. It's just making sure, checking in, making sure you're okay. And again, visually, blood is really scary, right? Especially the amount of blood. We're so used to it because we've lived it our entire life. We don't know any differently. To us, 15-minute nosebleed is like no big deal. To somebody else who's never had one in their life, they can't imagine, right? So we start to normalize that perspective, and that gets really dangerous as well, because we're creating a new normal for ourselves that we shouldn't have to live with. So by perpetuating that to other people, like, oh, it's okay, that's just how I live. It's like, no, I do live this way. And I know it looks really scary, but I can reassure you that I'm okay. It has nothing to do with what you did, as like it, and being honest. If it hurts, we need to stop. If something doesn't feel right, the more they're able to navigate, because they can't feel what you feel, the more they can navigate and sort of set those boundaries and understand what they are and what you'd like them to do and not do, the more they'll trust that you're telling them the truth, and the less hesitation they'll feel moving forward. I think it's equally an experience for them as it is for you, but while still putting yourself first, right? So the more honest and descriptive you can be to them over time, the more they'll understand, oh, that happened, but I know that's okay because of this, or that's actually new, I don't remember that, or, oh, she's communicated that this isn't happening. And it's almost like you gain the credibility that they can trust that I can do this and not feel like I'm hurting you because you've given me that dialogue and I understand. That makes sense, I hope.
Perfectly. Thank you so much. I really don't want to end, but we unfortunately have to. I knew that starting this conversation would result in running out of time, and it really feels like we need a part 2 to be able to deal with this, and I would love to do that at some point in the future. But I am interested to see what the feedback will be from our participants to what they heard here and saw here today. And I want to thank you all so much for taking the time out and also taking all this extra time to speak. If Chad, did you have something you wanted to throw in? Okay. Thank you so much for that. I just want to thank the panelists. I want to thank Magicom, the back-end tech company that's been helping us to put this on and whose platform we're working on, and Bayer, who made this webinar possible. I'll just let you know that once you leave the meeting, you're going to be redirected to a post-webinar evaluation. We'd love it if you could fill that out, because giving us responses to that allows us to put things like this together and start these conversations. Thank you all again so much, and have a wonderful night.